Those are usually off.
Okay. Works?
Yeah, perfect.
Good.
Okay.
Good morning.
Good morning.
Hey, Gina. You got a shout out last night, huh? From the Psoriasis Foundation people.
Yeah.
Can everybody hear us on the, you think they can hear us on this deal? We're good? Okay, you guys ready?
Yes, sir.
So, you guys have already seen these, right?
Yes, sir.
Good. All right, anybody want to give a quick little description of this lesion?
So I can start. This is a shave of papule. There's this kind of pretty well circumscribed proliferation taking up most of the biopsy in the dermis that looks kind of spindled. There was this, looks like there's this overlying kind of basaloid induction at both ends. One thing I thought of that does that is a DF, but I didn't see good kind of peripheral collagen trapping, and I don't think I've ever seen a DF that's really circumscribed or almost pseudo-encapsulated like this.
Yeah.
But it was a thought. There's these little kind of follicular elements within the dermis, in that section and also in the other one. But I didn't think that this was enough. I didn't think this was like what's the stroma for like a follicular tumor. I thought it was too cellular. Some of the bits on the other piece have that kind of storiform look. I didn't think it was a sclerotic fibroma or anything like that, so I kind of wasn't sure which direction to go on this one, and ended up calling it a DF.
It's kind of an interesting thing. This is the type of stroma that you see in the periphery of like a hair follicle. It sort of just goes crazy, and then these are little mantelloma-like structures. You just said this alone, you might even think it's a little mini trichofolliculoma.
Yeah.
But what this is a fibrofolliculoma.
Okay.
Yeah, and this is the stroma of the fibrofolliculoma. So this is kind of a perifollicular
was thinking that was
stroma.
less cellular. I don't know
Yeah, this is a little. This is kind of an interesting variant of it. It's just a little bit more florid than usual.
Okay.
But so obviously this. What I thought was most interesting is that it had this little mantelloma.
Mm-hmm.
So this is a little benign follicular proliferation of the mantle zone. So these are forming little primitive follicular structures here, kind of papillary mesenchymal bodies. It's not really a trichofolliculoma. It sort of looks a little like a trichofolliculoma with the stroma of what you see with the fibrofolliculoma, which is fascinating. So this is what you see in patients that have Burghardt-Dubé, obviously. And here are some examples. These things kind of look like little multiple fibrous papules clinically, or like little cysts or whatever. And you guys know what the cause of this thing is, and they also can end up getting other things. You got to make sure they're not renal cell carcinoma, pneumothorax, medullary thyroid disease. So there's one other trichodiscoma, fibrofolliculoma, perifollicular fibroma. These are probably all variations of the same thing. We just used to split these out, but we really don't do that much anymore. So anyway, it's a nice example of that, but it's just it's interesting because it's kind of an unusual variant. And sometimes the boards, if they need a large amount of tissue, so if they might show you something like this. It's got a little funny, the follicular component is a little different than what you see in a more classic one that you might read about in a textbook. All right, 137.
Shaved biopsy on ankle skin. Looks like kind of a darkly pigmented pursing center with some pigment all across the basal layer of cells. On low power, I thought this was kind of tadpole differential or paisley tie differential. And so I went with syringoma here because it's a little
excellent.
Like.
Good. So this is a syringoma. Now, what other things do you have to think about? You said there's a differential.
Yeah.
Here.
So morphiiform BCC, MAC, syringoma, and there's one more that I'm drawing a blank on.
Yeah, probably MAC would be the one that you really worry about the most. The one that you're drawing a blank on is probably desmoplastic trichoepithelioma. That can kind of sort of look like this. When you get these little ducts like this, probably the only one of those that really would fall into the differential in this specific case would maybe be a MAC. And those, as you know, are usually, you need a deeper biopsy. But theoretically, you could see this in the superficial component of the MAC, but the overall lesion looks like a fairly small little papule. We don't have the whole thing, but it looks like it most likely was probably something about this size. Looks like it didn't go from one past this area, and it kind of looks like it probably would have been about this. If you drew, kind of completed the circle, probably something like that. So this is a syringoma. You don't have to get a lot of atypia in a MAC, however, which is kind of interesting. So if you look at the actual cytologic atypia of individual cells comprising a MAC, they can look a lot like a syringoma. Now, there's two settings of syringoma. There's obviously the ones that are most common around the eyelids, like this. And then there's another type that can be eruptive that can occur in the groin area, the chest area, the suprapubic area. So those are other variations that you see, the so-called eruptive type. They can be seen in patients that have Down syndrome. So that's something to remember. Boards like to ask that kind of question. And so basically it looks pretty straightforward as you saw right there. Okay. 138. Where's Annie? She's supposed to sit here and tell me if I'm on time or not.
I'm there.
You're doing good? Got no
I
sorry.
can describe this one. This is a dome-shaped papule, and we can see that it has multiple vellus hairs. There's fat in the center of it. There's also cartilage, so accessory tragus.
Yeah, accessory tragus. Now, do you have to worry about the patient? If I were Nina asking you questions here?
Right. Usually if it's an isolated lesion on the face, no, I wouldn't worry too much about it, but I would look around and do a really good physical exam to make sure there are no other kind of branchial arch abnormalities.
Yeah, that'd be the one thing that, if you get one of these, they can sometimes have other abnormalities that are associated with branchial arches, branchial clefts. So this is a nice example of this. Is there anything in the differential diagnosis of this?
Yes.
Could an accessory digit look like this?
Vellus hairs really would be difficult to have vellus hairs and accessory digit.
Excellent, that's exactly right. You get the cartilage, but yeah, it would look more like you don't see the vellus hair follicles. Okay, park more. That's what you're supposed to be after telling me to do. All right, so here's an example of what they look like. Some people call them like ear tags, which is not really the best thing to call these because they actually are little accessory tragi. And that one at the top, he's got two. You might do like an exam on somebody like this to make sure they didn't have something else going on in the area. So again, these are maybe associated with other abnormalities. So the Goldenhar syndrome, that's some of the other things that you get there. Those epibulbar dermoids that can get like a lipoma of the conjunctiva also can be seen with that. So basically, really nothing else much looks like this, especially if you have that cartilage. Very good. All right, number 139. This is a good one.
Okay, so in this one, this is it looks like a shelled out. Can we go a little further out? So it looks kind of like a not shelled out lesion, but I don't see any epidermis here.
Yeah, good. If it's a skin lesion, it's certainly deep to the epidermis, right? Mm-hmm. Okay, so you got a lot of basically dermis, and then you've got some structures in the dermis, don't you?
We do have some structures. They look like kind of these glandular structures or ducts.
Yeah, good.
Some of them are blood filled.
Okay, good.
And looking at these, and there's a lot of extravasated erythrocytes as well, and kind of this loose fibromyxoid stroma.
Good.
So I was thinking either cutaneous endometriosis, but some of it looked maybe a little funny, and so I was thinking a cutaneous net of endometrial carcinoma.
Yeah, that's a good thought also. Usually, I haven't seen too terribly many of those.
Yeah, I was looking it up, and there's not very many.
They're usually pretty solid neoplasms. You probably wouldn't get multiple small duct-like glandular-like aggregations in that. If it were a mat, it'd probably like one really solid metastasis. You do have a couple mitotic figures in here, though. This is a proliferative epithelium. But that is the right answer. This is cutaneous endometriosis. This wasn't a met, was it, Mokhtar? So I think you see something that looks glandular, and it's got a lot of red blood cells in the glands. There aren't too many other benign adnexal neoplasms that tend to have that. Is that part long enough? And this actually is undergoing the menstrual cycle of the in the skin. So these things often they get painful with the menses and whatnot. So it actually is an interesting phenomenon. Where do these occur most commonly?
Periumbilical.
Yeah, kind of in the groin area.
Groin.
Often if there's been a prior surgery, and there is a scar in the background here, so
Like
this
a
may have been at the
cesarean
site of a
section.
C-section or something like that that developed there. Some people think this may be some kind of implantation process, but it's probably more kind of like a metaplasia in some way. This is probably it's got some cilia on the surface here, most likely, I would imagine. So this is cutaneous endometriosis. All right. Did everybody recognize this? Good. Pretty unusual, but a good one to know. All right, number 140.
All right, so here we have a thin shape. I think most of you have.
Oh, I forgot to show the picture. Let me show you the picture. Sorry about that.
No.
Yeah, this is what it looks like. Okay. Red-brown nodule. So these are just a couple of things. The differential cutaneous ciliated cysts. So those glandular spaces with that hemorrhage is really helpful. Okay. Now we're back to 140.
All right, so it looks like we have some superficial perivascular infiltrate. When I looked at it, there was a lot of plasma cells and lymphocytes. There was also some vacuolar changes. The architecture wasn't one that I classically think of for syphilis, but given all the plasma cells that I saw, that was definitely on the differential. I wasn't sure if I saw also some, given the vacuolar changes, the superficial perivascular. Thought I may have saw a little bit of mucin, so I put connective tissue also on the differential here, but
Okay, well, those are reasonable. So if you look at the pattern at low power, we don't have the base of the biopsy, unfortunately, but superficial and certainly mid, maybe possibly deep, but we don't know because we don't have a deeper biopsy. And it's got kind of a band-like infiltrate, so superficial and possibly deep, band-like infiltrate of lymphocytes, plasma cells, and also some histiocytes in here too. So we'll look over at this piece, and there may be a little kind of focal, it's not really well-defined granulomatous inflammation, but there are some histiocytes in here. So no sarcoidal granulomas. So syphilis tends to, when it is granulomatous, it usually is not dense sarcoidal granules. It can be, but it's not real common to be. But tons of plasma cells. So this is syphilis, so that's exactly right. What are some of the what's the most common histologic pattern of syphilis?
you have like the elongated reedy, acanthosis.
Yeah, superficial and deep psoriasiform lichenoid. That's the classic form of secondary syphilis, but you can see some that are just superficial perivascular. You get some that have a lot of interface change and almost look like pityriasis lichenoides. I've seen some that look almost exactly like lichen planus. I've seen some that look like psoriasis. So syphilis can look like a lot of things under the microscope too. It's the great imitator both clinically and histologically. You have a special stain to kind of prove that it was syphilis in this case. I'll show you that in a second. So again, when you see this many plasma cells, and it's not on mucous membrane, it's not like associated with something on the face like seborrheic dermatitis, you should at least think about syphilis. And here is the stain. So we have two stains that we use today primarily. You can use a Warthin Starry stain, which is not that great, or you can use a Treponema pallidum stain. And supposedly this one's positive. Not real positive. Is it faded or was it positive before? There it is, right there in the dermis. So this doesn't, this time the spirochetes are down here. So these are pies. See right there? Curly cues. Here's another one right there. A lot of times they're in the epidermis. In fact, most of the time they're in the epidermis. This time they're down in the dermis, which is interesting. So you can see them really nicely at this power. Okay, so secondary syphilis. And this is what it looks like clinically. So little ham-colored macules, little papules or plaques in the soles, and the little sort of scale at peripheral colorado epithelium is very characteristic. And then the widespread papular eruption on the trunk and extremities. The moth-eaten alopecia, condylarthra, etc. So you all know what the clinical manifestations are of syphilis. Plasma cells usually positive, usually seen, but sometimes they can be relatively few. But in my experience, that's one of the things that does help you because they almost always are present. All right. Everybody got that one?
Yep.
Good.
Okay, so we have patch biopsy, non-equal skin, and the dermis really didn't tell me very much, but the epidermis looked a little bit like papillomatous.
Yeah, there's a slight amount of acanthosis here. I would agree with that.
Mm-hmm.
Where's the main pathology this time?
The main pathology, I think, well, there's a slight superficial perivascular infiltrate.
Yeah, it's very subtle though, isn't it?
Yeah, in the other cut maybe it's a little bit more noticeable, but it's subtle, yeah. And then
The main changes are
on
up
the,
here.
Yeah, in the epidermis.
in the cornified layer
Yeah.
of the epidermis.
So yeah, in when you see in detail in the cornified layer, there are some non-human findings.
Non-human organisms, okay. So what was up here?
So these are, yeah, these tiny round organisms that I think that is probably tinea versicolor.
Yeah, you've got the round spores here, and you've got a hyphae.
Mm-hmm.
And so that's what some people refer to as the so-called spaghetti and meatballs kind of appearance. Now, what else, what's in the differential diagnosis of this when you see this in the cornified layer?
The first I thought when I saw it without seeing all these, I thought of carp.
Good.
Based on how it looked. I'm not sure if you were, if that's what you expect to.
Yeah, that's one thing that you would think of just looking at the epithelium. If you didn't see the cornified layer, carp is a good idea. In fact, sometimes these patients look a lot like carp clinically also. They have tinea versicolor. So yeah, that's one thing. What about the organisms? What's in the differential diagnosis of the organisms in? So let's say you recognize these are here. If you're going to be taking a board exam, what kind of things are they going to put on the exam to kind of try to fool you?
Well, if you just see the hyphae, you don't see the yeast, you may think like a dermatophyte.
Yeah, dermatophytosis might be one. What else might you think about?
Candida.
Candida. What about erythrasma? They might put that on there too. They might say, some guys are going to see that in the cornified layer and think those are bacteria. They're not used to looking at things under the microscope.
Yeah,
Notice how large these hyphae are. They're very large, much larger than the hyphae of a dermatophyte. And you don't see these kind of spores of dermatophyte. You might see occasionally some chlamydospores, but you don't see these larger spores. These clusters look like almost like grapes. So that's this is tinea versicolor.
And Corynebacterium would be much smaller.
Much smaller. Yeah, they're very, very tiny. So here you get the guy in the wintertime where it looks brown, and in the summertime it looks white. And why does it look white?
Because it inhibits the...
Yeah, what's the chemical that
Azelaic acid.
Azelaic acid. Good. So tinea versicolor is a nice example of that. So it fools clinicians. We actually get, like biopsies.
Dr. Cockerell, I heard somebody teaching that carp is commonly associated with the tinea versicolor.
Yes,
that
it can
lives
be.
in carp.
Sometimes you treat the tinea versicolor and then the carp goes away.
Do you think it's an association, or do you think it's actually just tinea versicolor?
I think sometimes it's just associated or just true unrelated, but sometimes it may be actually caused by it in some situations, or a carp-like process maybe.
I've always wondered that
Is
as well.
pigment dropout typical in tinea versicolor? Because I thought I saw some melanophages in pigment.
It's unusual. Not usually. You may get a few melanophages, but
Okay.
not a lot.
Because I was thinking pigmenting purpuric eruption. I didn't even look at that.
PPPD would be
Yeah.
more erythrocytes. So
Erythrocytes.
that's red
Okay, that's the
cells.
thing that was missing.
Yeah. All right, this is a beautiful example of this.
So this is a shade of a papule, and there's this stringy basaloid proliferation kind of emanating from the epidermis that's kind of crisscrossing and connecting in these thin strands. So I thought this was good for pincus or fibroepithelioma pincus.
Yeah, this is a fantastic example of that. Now, since it's such an easy, obvious thing that you can get at 1x, what's in the differential diagnosis of this?
The syringofibroadenoma looks a lot like this as
Excellent.
well. It has
Very good.
little ducts in it.
Good. So if you just had these little strands like this, you could say it could be a syringofibroadenoma. It looks pretty similar to that. But you don't get these structures that look a little bit more like a basal cell carcinoma than that. Okay, so that would rule that out. Notice the stroma. It's very fibrotic. And so if you get one of these, you really don't want to D and C it because it's going to be the stroma is so thick you're not going to be able to curette it away. You have to actually excise these. They tend to behave in a very indolent fashion. Although they're classified as a form of basal cell, they don't really behave like a classic basal cell carcinoma. They usually just kind of sit back in somebody's lower back like here, and they don't really change that much. Occasionally you'll get one that might sort of crust over and it looks like a little focus of nodular basal cell carcinoma arising in it. So fibroepithelial tumor of pincus.
So you don't have to have the clefting and all that. For it
Not
to be-
really,
okay.
no. If you see this, you can make the diagnosis even without
Yeah.
the clefting. It's got the little basal cell-like aggregates superficially with the little anastomosing strands and cords in here.
Is
So-
there anything else that has an anastomosing epidermis? Is there anything else in differential? I thought there was something else.
There's one other one, but not usually to this degree. Tumor of the follicular infundibular.
Tumor of the
Can give you some of that same
follicular,
thing.
okay.
But usually that's pretty much confined to just sort of these areas up here. It's very superficial. It doesn't really extend down this deeply. You usually don't get these really thin anastomosing cords in that condition. All right, 43. We're having pretty good on time, I think.
This was a punch biopsy, and kind of main pathological finding of what I was drawn to was the lower part of the biopsy, the deep dermis, and this one of the cuts a very large open space, real kind of jagged pink lining that I called like kind of a shark tooth lining. So I was going for a steatocystoma.
Okay. Anything else kind of help you other than this, the lining?
All the sebaceous glands around it.
Yeah, that's a nice thing when you get this many sebaceous glands actually in the wall of the cyst. Very characteristic. And this is the little jagged, irregular lining of the cyst with this pink, sort of hyaline-like cuticular surface. It's very characteristic. So even if you don't see the sebaceous glands, you can still suspect the diagnosis if you have that lining. Do you think this is the simplex form or the more multiplex form?
Well, there was just one in the cut. I'm assuming that's probably the same one.
Yeah, it's possible. I mean, I don't. This might be a couple together. I
Okay.
don't know.
Well,
So
a
it
couple
might be
together, then maybe
multiplex. You
multiplex.
don't really need to know that for the boards, but the fact that you recognize this, that's important. And what other kind of cysts can sort of look like this?
I don't know.
Okay. Anybody know?
Dermoid.
Yeah, dermoid.
Can have the sebaceous glands, I think, in the wall.
Yeah. that's something else to consider. And then what else?
Without it's just a single cell lining like a hydrocystoma or single or double cell, but it doesn't have the cuticle.
Exactly.
Right.
We have a cuticular lining like that. And then what about a vellus hair cyst? It doesn't have quite the cuticular lining as well, but it can look sort of similar to it sometimes. Sometimes you only get the sebaceous lobules, you get the little small vellus hairs in the center of the cyst in that case. So here's an example of a couple of these. Is this transmitted in hereditary fashion?
Can be.
Yeah, it can be autosomal dominant. It's got a keratin 17 mutation with it. It can be associated with some other things like eruptive vellus hair cyst and pachyonychia congenita, so make sure you know that. So, and yeah, you can actually, when you cut into these things, you'll often see some oil, secretion, which is interesting. Okay, 44.
So this is a shape biopsy, and on high magnification, you kind of can see almost like granulomatous inflammation. You can see a lot of dark pigment, very foreign material. So if you zoom in, I really thought that this was a tattoo, and a possibly either granulomatous reaction to tattoo or another entity that likes tattoo, which is sarcoid.
Yeah, so this could be sarcoid itself that was maybe precipitated by a tattoo, or somebody had sarcoid, got a tattoo, and it kind of localized to the tattoo area. Or it could just be a granulomatous reaction to the tattoo pigment in an individual that didn't have sarcoid, because you can get sarcoidal granulomatous inflammation in tattoos when they don't have sarcoidosis. So this is a nice example of that. Do you know what the material is?
Well, carbon tattoo or just a black tattoo, really.
Yeah, some of this sure looks a lot like carbon, although it's also got these little tiny small droplets in a way, so this may be kind of a dark carbon containing ink rather than just a carbon tattoo from a pencil lead. What are some other tattoo pigments that you have to know about?
Well, other colors, you would recognize them, but you probably want to recognize them on cells as well. It looks a little different. Other foreign body materials that are dark, you probably want to recognize the metaceous fungi that produce pigment.
Yeah. What's the red tattoo color due to?
Mercury.
Yeah, what's that called? Cinnabar.
Oh, cinnabar.
Yeah. And what about the blue color?
Blue color, cobalt.
Yeah, and what about the yellow color?
And cadmium.
Yeah, good. So they like to ask those kind of questions. So here you see somebody, this is a dark-skinned patient. I think they actually had sarcoid and it localized to the tattoo here. So the other situation where we saw this a few years ago are some of these organic tattoos, the ones that they put on the eyebrows, the eyelids. Those are terrible tattoo pigments, and they actually had a small epidemic of that a few years ago. So these are a couple other things. The Schaumann bodies, you should probably just know what those are. They're little calcific laminated inclusions in the asteroid bodies and stellate. So that's a nice example of sarcoid rising in a tattoo.
Okay, and this looks like a shave biopsy of maybe a pedunculated lesion.
Yes.
And it has these really interesting structures, and on closer inspection, they look like goblet cells.
Yeah, there's a lot of those cells, aren't there?
Mm-hmm.
Cells that have
Quite a bit.
producing mucin.
Mm-hmm. Producing mucin. There's also newts, blood, eos, lymphs, and so I was thinking some sort of GI type process. It could be a congenital umbilical polyp. What I was thinking.
Okay.
Architecture.
Like the lower magnification. What is the shape of the lesion?
Polyp.
Yeah, it looks like a little polyp, doesn't it? It's kind of a sessile lesion here. It's dome-shaped.
Mm-hmm.
And it's got a little central sort of almost core, if you will.
Mm-hmm.
and then it's got maybe some fibroplasia surrounding this, and then it's got this superficial erosion. What do you think this would have looked like clinically? Would it have been a smooth surface lesion, or?
No.
No, it's kind of eroded, isn't it?
Mhm.
It's got some neutrophils on the surface. Why do you think that is?
There's infection?
It could be, but we don't see any bacteria up there.
No.
So maybe this stuff is producing sort of like a hydrochloric acid or something like that.
Causing
It's kind of
inflammation.
causing some irritation, yeah. And also, this type of epithelium, it isn't designed to protect us from the outer world, is it?
No.
No, this is designed to digest food.
Yeah.
So it should be living inside your body, not outside on the outside of the body.
Cutaneous Crohn's, something else I was thinking of, but I don't.
Yeah, what's the histologic pattern of cutaneous Crohn's disease?
It didn't look like this, and I was looking it up. I didn't notice.
What's the if you do a biopsy of somebody's GI tract with Crohn's, what do you see there? Crohn's inflammatory disease.
Flattening
Right?
of the villi and
Granulomatous inflammation. Yeah, it's like a sarcoidal granulomatous inflammation. So this doesn't really have any inflammatory infiltrate except at the surface where maybe it's kind of got an irritant reaction.
I'm not sure what this is.
Well, you actually knew what it was.
Oh, okay.
You called it an umbilical polyp.
Congenital umbilical polyp. Yeah.
Which, what is a congenital umbilical polyp?
Is it the Apollo?
Mesenteric.
Yeah,
Mesenteric.
Mesenteric duct, or whatever they call it. And so here you can see the normal squamous epithelium, and then right here, a nice transition zone between the gastrointestinal epithelium and the squamous epithelium. And this is eroded over here, and this is doing its job, producing a cornified layer. So this is basically what it looks like clinically. These little papules like this, they're usually kind of glistening and they're kind of irritated. So Mesenteric duct cyst. It's kind of a funny name because it's not really a cyst. I kind of like the polyp idea a little bit better.
Yeah.
So it's not truly a cyst, but this is basically, if you were to track this back, it goes into the GI tract in many cases. So you want to make sure before you cut this out, you don't just open up something that goes straight back into their GI tract and create like a fistula or something like that. This is a beautiful example of this, though. Now, what's the one major item in the differential diagnosis of this?
Ectopic GI tissue.
And where do we usually see that?
Neostomas.
Yes. So like a stoma reaction where you get GI tissue that grows onto the skin. It's a kind of a metaplastic type of process. So that can look exactly like this right here without the polyp. So if you have a little magnification, you see that it's a polyp or a little papule, you can make the diagnosis. But if you didn't have that, you just had this, peristomal gastrointestinal epithelium metaplasia could look like this. It looks exactly the same. And that's usually pretty red and irritated and inflamed also.
And the limit is such that it's as sharp as it is in this case?
Usually it is, yeah.
It's not like a gradual, it's
No,
basically.
you'll see squamous, and then you'll see a little bit of epithelium that's GI, and then you'll see straight GI epithelium. All right.
Alright, so here we have a punch biopsy. It looks like most of our pathology here is in the dermis. If you go on higher power,
You think it's an inflammatory or neoplastic process?
it's neoplastic
Yeah.
process.
Benign or malignant?
Benign.
Okay, yeah, it's good. It's benign, but is it small?
No, it's large.
So it kind of breaks one of the
really,
rules,
really
right?
big, yeah. But
Big, but it's very
well
symmetrical.
circumcised.
Yeah.
Symmetrical.
It's beautifully symmetrical.
It's-
What color are these cells?
It's kind of purple blue, I guess, or blue-ish.
Well, this is more purple.
Purple, okay.
But what about this? Pink or light. Kind of clear at low magnification, isn't it?
Mm-hmm.
So here's some stroma that's pink, and these cells look kind of clear because
Right.
they got a lot of cytoplasm.
Right.
So we're going to have magnification. Did you think this was epithelial or non-epithelial?
Non-epithelial.
And if it's epithelial, it's kind of a different type of epithelium, isn't it?
Alright. You can see they're real cleared out. Cleared out cells, so this looks like a granular cell tumor.
Yeah, so there's clear cytoplasm, but you look inside there are these granules inside the cytoplasm. So this is a granular cell tumor. Now is that epithelium or not epithelium?
That's a good question. I mean, it's from the end.
What's the derivation of this thing thought to be? Yeah, it's kind of thought to be from the neural crest.
Okay.
And so that's a type of epithelium.
Mm.
So this is really sort of an epithelial neoplasm in a way, which is comprised of granular cells. And let's say you wanted to stain this to prove that it was granular cells, say not like a xanthoma or something like that.
Mm-hmm.
What stains would you do?
So you can do like S100,
Yeah, S100 is strongly positive.
and then
What if you didn't have an immunoperoxidase lab and you just needed to stain it with a routine stain?
like a PAS.
Yeah, good. PAS stains these.
That's
The
nice.
granules are lysosomes that are chock full of myelin-like byproducts, it's thought. And so it stains positive with PAS. So good, this is granular cell tumor. Now, what if this was a malignant granular cell tumor? How would you diagnose that from just a large, benign granular cell tumor?
I've never seen it. I imagine you see more mitoses. It wouldn't respect the
Yeah, it's
boundaries
much more
as much.
asymmetrical. Cells are strikingly atypical, a lot of mitotic figures. So this is obviously doesn't have any of those. And then what's one final thing that you have to worry about in these lesions?
Perineural invasion?
No,
Location.
no, not so much. This doesn't have it, but you can often get pseudoepitheliomatous hyperplasia overlying these. And if you get a shaved biopsy that doesn't get the granular cells, which maybe gets 4 or 5 of them, you can't really see what's going on, you can get an overdiagnosis of squamous cell carcinoma. And you said location. Where's one of the most common locations of these?
Tongue.
Yeah, the tongue. A picture of that here. So that's this guy's tongue on the right. Notice he's an African American man. That's actually a fairly common neoplasm to develop in dark-skinned patients, especially African Americans. And so you don't want to call it a squamous cell on somebody's tongue, and then they have to wipe out their tongue and all that stuff. That could be a big problem. So just remember that you can get pseudoepitheliomatous hyperplasia in these lesions. We used to think these were muscle tumors. They used to be called myoblastomas. So myoblastomas, we now know that they're not muscle in origin. Okay, everybody got this one right? Good. Okay.
So we have a punch biopsy. It looks like there's a lichenoid infiltrate.
Yes.
But that's not the only thing. So it's predominantly lymphocytic. There's a lot of red blood cells extravasation.
Good. What part of the body are you on here?
I thought it was lower extremities because of
Good.
I went through a lot of thoughts.
You said because you thought it was lower extremity, but why? I interrupted you. Why did you think it was lower extremity?
So there are a lot of blood vessels.
Good.
And many,
Excellent.
yeah,
And they're very thick walled too, aren't they?
some of them look thick walled, some of them look a little bit more irregular, but yeah. So
Yeah,
I,
so that's kind of like stasis altered skin. They
Stasis.
probably don't have stasis dermatitis, but they've got stasis altered blood vessels. So that's
Mhm.
excellent that you're able to recognize that.
so within the non-neoplastic things that I thought about, I thought of stasis derm. I thought of, but there's no like eczematous changes to think.
Good.
So then, other thing that could be is PPD,
Good.
pigmented pubertic dermatitis.
Good.
And within those, it's Bouger bloom is the lichenoid
Yeah,
one.
excellent. So
Yeah.
Bougereau bloom,
Yeah.
or lichen aureus, which is kind of another name for that. And why is it called lichen aureus? What does aureus mean?
Because it's golden.
Golden, yes, good.
Looking legs, you know.
Yeah. And the gold comes from it's not really gold, it's hemosiderin, right?
Mm-hmm.
Now there's a plasma cell here. Should we work the patient up for syphilis?
No, you can see plasma cells in.
Yeah, any kind of chronic inflammation, you get a few plasma cells here and there, so no, we're not going to work this patient up for syphilis. Anything else from a lichenoid differential that you'd have to think about here?
Well, from the lichenoid infiltrate perspective, right now I cannot think of.
So you're so confident it has to be lichen aureus, you
Well,
wouldn't even think of
I
lichen
am not
planus
so-
or
well, it
lichenoid
could be like
syphilis or anything like that, okay.
I mean, but it doesn't have all the features in the
Good.
epidermis for lichen planus. That's
Yeah, it doesn't have the irregular epidermal
Yeah.
and then you have a granulosis, wedge-shaped hypergranulosis, and those things, so probably not lichen planus. And you can get a lichenoid form of syphilis, you know, and there are a couple of plasma cells here and there, so he's got 4 right there together, 5, so.
He gets an RPR then.
okay. You got that right?
Yeah, and you know, this guy was probably about 75 or something like that. Well, this is
So he
if he,
definitely gets an RPR.
if he had this, yeah, especially lives at the villages or something like that, right? So, anyway, that's what it looks like, lichen aureus. That's what it turned out to be this time. So, yeah, you can get an occasional plasma cell in that too. Just don't let that fool you. Did have a lot of the hemosiderin, and it's differential PPPD lichen. This is basically kind of a variant of that process. It's not really a true distinctive condition.
I was thinking psoriasis lichenoides chronically in this one. Is that?
That's a good idea. Now, there's several things against that. It does not really and truly sort of affect the interface. You notice there's a little teensy tiny grin zone. Usually in psoriasis lichenoides, you're going to get like total obliteration of the interface with cells sort of crashing into the epidermis. Also with parakeratosis with neutrophils overlying it. But you do get extravasate erythrocytes in that. But the other features of that aren't present. So just like the features of lichen planus really aren't present, and some of those other features of psoriasis lichenoides aren't present. That is in the lichenoid differential.
Okay, thank you.
The only thing I thought of was PPD like MF. They can mimic.
Yeah, that can look somewhat similar, and of course that will give you more epidermotropism and the atypical cells in the epidermis. So. Okay. A difficult one, right? Is this for Jay? He gets the hard one, the DERMPATH fellow who knows more than Gina and Jay. They shouldn't be allowed to do this one. This should be like a medical student. Good Tiffany around, she could do this one. All right, so the challenge then, since you know what it is, how are we going to make it hard? So you're now writing the board questions. You're going to put this on the exam, so this is going to be so easy they're going to think that we're like stupid that we show a classic molluscum contagiosum here. How are we going to make it hard for them? So what kind of questions can we draft that will make them think?
What type of virus is
Yeah,
this?
what type of genome?
Okay, what type of virus is it? What type of virus is it?
Single-stranded
Double-stranded DNA, single-stranded DNA.
Okay,
Pox virus is double-stranded DNA.
right, double-stranded DNA.
Or you
And then-
could just show a picture like this.
What are the bodies?
Henderson-Patterson.
Okay. If this was smallpox, what are the bodies?
Guarnieri.
Guarnieri, yeah, good. Guarnieri. Is Guarnieri, was he Argentinian or where was he from? Italian.
Italian Muslim.
Could have been Argentinian. Name some other pox virus diseases. We've said smallpox, molluscum. What are a couple others?
Cowpox, monkeypox,
Tanapox,
rabbitpox. Made that up.
Milker's nodule,
Yeah.
right? Variola is smallpox. Okay, so anything else about these? What are the RNA viruses generally cause? What kind of cutaneous manifestations of those, like flaviviruses, the RNA virus? What do they look like clinically, as opposed to the pox viruses, usually just some kind of a boggy plaque or nodule or a wart-like lesion, that sort of thing. What are the RNA viruses usually cause?
Like exanthems?
Yes, exanthems,
Yeah.
measles,
Coliform.
those kind of things. So that's just a general rule of thumb. If it's more like this, it's more likely to be a DNA virus. If it's more like an xanthan, it's more likely an RNA virus. What are some other items of the differential diagnosis of this clinically?
Crypto, histo,
Good.
cox.
Cocci,
Cocci.
possibly, it'd be a little unusual. There's one or two others. What if they came from Thailand? Penicilliosis. What if they had a pneumonia that sort of looked like bubbly Swiss cheese on the biopsy that was positive with GMS?
Crypto?
No.
Say that.
What's the type of pneumonia that HIV positive patients get? Pneumocystis. And that actually can sometimes cause molluscum-like pathogens. And we actually wrote that up a long time ago. This is more Jay's category, or Gina.
Yeah.
This is more you guys.
I'll attempt it, then I'll pass. So I got a shave biopsy on what I thought was acral skin here. Very well circumscribed, dermal-based papule. Epidermis looked kind of like it was a little atropic, so it was being pushed up on by this ball of dermis. I call this a sclerosing perineuroma.
Well, how about that?
Hey.
Maybe she needs to do dermpath.
No. Thank you, though.
Sclerosing perineurioma.
Neurioma. I don't get that part.
Well, what's in the differential diagnosis of this?
I had written down, so I went down my acral bumps differential. I wrote down acral fibromyxoma, but it wasn't obviously myxoid enough for
Good,
that.
excellent.
And then I was thinking like bumps on the hand or bumps on the foot, like the glomus, but that didn't fit. So,
Right.
like fibrokeratoma maybe.
Yeah, that's a possibility. Again, what's not so good for that?
And it doesn't have the Colorado scale. Fibrokeratoma should have kind of endo-exophytic look, I think.
Well, there's one main reason. It doesn't have all the cells. So you get all these little round cells here, some are forming little whorls around some of the pre-existing blood vessels, possibly or a little nerve. That you don't see in acquired digital fibrokeratoma. What about a wart? Can you get like a sclerosing angiofibroma-like morphology in the stroma of an old acral verruca?
Oh, I'm sure you can.
You can, but it doesn't usually have these sort of whorls of these little epithelioid round cells like this. Now, if you're going to stain this, what are you going to stain this with?
EMA.
Yeah, they should be positive for epithelial membrane antigen. We had a case that we're working up right now that histologically looks exactly like this, but it's not really staining that positively for EMA, so I don't know that they always do stain super positive. So, perineurioma, why is it called perineurioma?
I'll pass to Gina on that one.
Probably solid origin.
Yeah, so what's this I'm pointing at right here? Isn't that a little nerve right there? Yeah, it's probably a Schwann cell on the outside, so it's probably a little axon. So this is probably, these cells out here are the perineurium, around the nerve, not the endoneurium. These are around the nerve, and so this is what this lesion is comprised of. So it's kind of a nice example of there's a little nerve twig that's left, and these cells are all developing around this thing. Pretty nice example of it. Maybe another one right here possibly, but you see how it kind of chokes off any existing nerve twigs that are left. So the perineurium is that little sustentacular sort of connective tissue structure that's around the nerve. And that's what is forming this neoplasm here. So yeah, this is going to be S100 protein negative, right? And if you did a neurofilament, you might pick up a couple of these residual nerve twigs in the thing, but it's going to be largely, this is kind of a soft tissue tumor that's related to the lining around the nerve. It's not Schwann line, not Schwannian, it's not Schwann cell tumor. This is a different type of tumor. So this is what they look like. They can kind of look like a acquired digital fibrokeratoma or like a poroma or some kind of non-specific when you look at them clinically. And then if you see this on the biopsy, it's really characteristic. So you get this little whorling storiform pattern quite common, the onion skinning around the structures.
Why is this 100 negative?
Because it's not really Schwannian in nature. It's really not the actual nerve that's right. This is the lining structure around the nerve that's the structure. It's an epithelium in a way. All right, the last one. 10 minutes to do this one. Gosh, we can really kick somebody's brain.
That would be mine. Alright, this is a punch biopsy with a very dense inflammatory infiltrate that's going deep. Lots of papillary dermal edema. There's looks like a crust overlying it.
What kind of cells are in it?
Yeah, those are neutrophils.
Why neutrophils at low power?
At low power, they're very small, very dark, very basophilic, and almost.
But not as dark as lymphocytes, right?
No, not as dark.
Some of these may be
Almost
some
empty,
lymphs
really.
here. Yeah, and you can see that it's also got kind of a little, just very tiny clear structures around it. That's kind of characteristic of neutrophils, kind of like a salt and pepper like morphology as opposed to jet black at low power. So you'd be able to recognize pretty quickly with a higher magnification of neutrophils. But so when you see this pattern of a dense diffuse infiltrate with neutrophils and papillary dermal edema,
You have to think of sweets.
you must think of sweets. Exactly. So that's the diagnosis here, sweets.
On low power, if you weren't paying attention to the composition of cells, you could think of pernio and PMLE in this
Yeah,
type of
you could.
biopsy.
Now, why would you not think of either one of those at low power, even if you didn't, even if you thought they were lymphocytes?
Yeah, for pernio, you really want it to be more perivascular, periadnexal,
Yeah.
kind of denser infiltrate there.
Good. What
For
about polymorphous light eruption?
for PMLE, not so dense.
Good. So you don't get dense diffuse infiltrates with those. They're more perivascular, maybe a little interstitial with pronio, but it's more perivascular and not dense diffuse.
Yeah.
So this is one of the conditions like septic granulomatous dermatitis, infections and abscesses, things like these are dense diffuse processes with polys. And then you get papillary dermal edema, it's almost certainly sweets. Now what's in the differential diagnosis of this besides sweets?
Yeah, you have to think of early kind of pustular PG.
Good, pyoderma gangrenosum,
Yeah,
absolutely could do this.
That would be a clinical differential really at this point. For other neutrophilic dermatosis, infection.
Good, you think of infectious processes. What else?
For neutrophilic.
There's kind of 3 or 4 histologic close identical twins, if you will. They're not exactly, but they all have dense diffuse infiltrates with relatively abundant neutrophils like this. So there's a pyoderma gangrenosum sweet. So what are a couple of others that fall into that category?
Leukocytoclastic vasculitis, but
It's possible. Possible. There are. What kind of leukocytoclastic vasculitis gives you pustules, neutrophils predominantly?
pustules. Yeah, that's it.
The IgA mediated ones.
Oh,
HSP, Finkelstein's,
yeah.
hemorrhagic edema of infancy.
Mm-hmm.
Lots of polys in IgA mediated vasculitis. A lot of times fairly intact polys. So what else? What else can give you lots of neutrophils?
Lots of newts.
What if they've been to see Dr. Kim that's on the billboard out there that likes to put in gastric sleeves and work on your GI tract, make you lose weight? What kind of neutrophilic infiltrate do you get in that condition?
Badass.
Yeah. What does that stand for?
Associated dermatosis and
Arthritis,
Arthritis
right? So
syndrome.
the badass syndrome is sort of an R-rated name, but that's seen with bowel bypass, we used to call it. Where else can you get a lot of polys?
Yeah, the
What if they have like an iritis and they get a pustule in the anterior chamber of their eye and they have arthritis and erythematosus and Behçet's disease. Behçet's disease. That's another one where you get a lot of polys. Okay. And that's most of them.
Yep.
You can see sometimes you get abundant neutrophils with the palisaded granulomatous rheumatoid
PNG.
dermatitis, and rheumatoid neutrophilic dermatosis.
What
You
exactly is the pattern
get
for
neutrophils in that?
the palisading?
It's more of an interstitial histiocytic infiltrate, but you get quite a bit of neutrophils in there also, which kind of helps
Okay.
distinguish from granulomannulary. Okay. Now, do we need to worry about this patient?
Yes, we do.
Yeah, we do.
You have to have a good review of systems and a good history. Cancer, underlying malignancy. The most common causes are really preceding infections. So you have to ask, have you been sick lately? So you have to worry about malignancy. AML commonly does that.
Hematologic malignancy, very common association with this. You want to make sure they don't have that.
Yep, and you have to ask about medications. The GM-CSF can do this.
Yes, can do it. What's usually different when you look at GM-CSF related suites and just garden variety suites like this?
Yeah, you probably, because those patients are neutropenic often, so they don't have neutrophils to do this, so you may see granulomatous.
Yeah, you get histiocytes quite commonly. It's GM, granulocyte monocyte colonies. The M gets put into this. Now, this has a couple of EOs in it.
Oh, yeah, so this was
Does that mean it can't be suites?
Say what?
Does that mean it excludes suites if there are EOs in it?
No, absolutely
You
not.
can get some EOs in suites, and you can also get some nuclear dust in suites, like we have here. So that doesn't mean that it's vasculitis, it's nuclear dust. So all of these things we see in suites. Sometimes you'll get some secondary vascular inflammation. It's not usually true vasculitis here. Okay, I think we kind of beat suites up pretty good. How are we doing on time? 3 minutes, perfect.